Welcome everyone to our November webinar. Tonight we have Dr. Uri Soiberman from the Wilmer Eye Institute presenting on manual DALK techniques for keratoconus. So all participants will be muted throughout the webinar. Please do ask questions, enter them into the Q&A panel, and they'll be answered at the conclusion of the talk. We'll have some discussion. We do not have a webinar scheduled for December, so you guys are off for the holidays, but we are putting together a really exciting program for 2023, so stay tuned to your email for those. And as always, this webinar and all of our webinars is recorded and available on demand at eversightvision.org/webinars. And so I'll just give a brief introduction of Dr. Soiberman before we get started. So Dr. Soiberman is an assistant professor of ophthalmology at the Wilmer Eye Institute. He specializes in medical surgical management of corneal disease, including transplants, cataracts, complicated IOLs. He's particularly interested in novel treatments for keratoconus, which is his primary research focus. And tonight we're going to learn about his expertise with surgical management of keratoconus through manual techniques for deep anterior lamellar keratoplasty. And so now I will hand the meeting over to you, Dr. Soiberman.
Hi, Michael. Thank you. Good evening, everyone. And thank you, Eversight, for this opportunity to present on this important, interesting subject. So we're going to be talking tonight about manual deep anterior lamellar keratoplasty for keratoconus. And these are my financial disclosures and some of these funding mechanisms to help me to do my keratoconus research. So we're going to be talking or reviewing alternatives to big bubble deep anterior lamellar keratoplasty for the treatment of keratoconus. We'll also review groove and peel DALK, which is an alternate way of doing deep anterior lamellar keratoplasty. I think it makes it much easier. So we know that keratoconus is a big problem for us cornea experts. It's pretty common corneal ectasia, and the incidence has been reported to be as high as 265 out of 100,000. It can be even higher in specific areas. And the problem with keratoconus is that it's a disease that starts early on in life. So unlike cataracts or glaucoma, this is a disease that the patients carry with them for their entire lives. So it has a lot of impact. We also know that there's a subtype for this disease, the rapidly progressive disease, which is much more common in younger patients. And these patients need to be cross-linked. Now, deep anterior lamellar keratoplasty is really a treatment for patients with more advanced disease. We know that cross-linking doesn't improve vision in adults. We know that it doesn't really improve vision, at least by much, in advanced keratoconus. So patients with advanced keratoconus who cannot tolerate contact lenses or are not good candidates for intrastromal ring segments are really great candidates for deep anterior lamellar keratoplasty. So we know that DALK is better than PK for these patients because, first of all, we just replaced the stroma. The endothelium is preserved, so the chances of endothelial rejection are essentially zero. And because there's never perforation of Descemet's membrane, then the mechanical stability of the eye is preserved. So this might be better for these patients as they grow older. We've all had patients who've had falls, those PK patients who come to us with DHEST grafts. So hopefully the next generation of cornea specialists, if we do more of these adults, will not have to deal with DHEST PKs. Also, this is not an open eye surgery, so it's great both for the patient and for the surgeon. And theoretically, it doesn't require a super high endothelial cell count, assuming that you can complete the surgery without perfing the cornea. This is the results of a meta-analysis that was published in Cornea in 2016. And essentially what it showed is that there is no big difference between DALK and PK. This was a meta-analysis of randomized controlled trials. There was no difference in the proportion of eyes with the best corrected visual acuity of 20/40 or better. There was no difference in spherical equivalent or astigmatism. The endothelial cell loss was much higher in the PK group, and there was a lower frequency of graft rejection in the DALK group as expected. So overall, DALK was the same or better than PK. So if DALK is so great, why don't we do it so much more frequently? So it's just much more difficult to do DALK, especially if you're trying to do a big bubble. There's a steep learning curve. Getting a type 1 bubble in advanced keratoconus is not always super easy. And sometimes you just get the wrong bubble. You get type 2 bubble, and that makes everything much more complex. And even if you do get the bubble and everything is wonderful, there's still a risk to perforate the cornea when you're removing the last bits and pieces of the posterior stroma, those little leaflets. So overall, it's a stressful operation and it's difficult to perform. So there are many ways to do DALK. Big bubble is by far one of the best ways, but viscodissection or manual dissection are other options. And under manual dissection, I grouped here lamellar dissection, the Mellis technique, groove and peel, and also grip and rip. These are all options for manual DALK, which provide excellent results. I'm going to show you some of them today. So without further ado, let's dive into the real presentation and talk a little bit about patients. So this is a keratoconus patient. Vision is count fingers, pinholes to 2800. This patient was contact lens intolerant, did not improve with refraction. As you can tell here, the Kmax is 70 diopters. So it's pretty advanced disease. And in this case, we went ahead and did, we tried to do a big bubble. So let's see what happens here. So we're starting off with a guarded tree-fine blade, a lamellar dissection. I introduce a Fogla dissector and I try to create a big bubble, but unfortunately I'm just getting this emphysema. Everything turns white. So I'm using this Pofique knife to go ahead and remove as much of the cornea as I can. This is me removing the endothelium, and now I'm looking at the cornea. I realized that I did get a big bubble, which I then popped. And this is how the eye looked at the end of the surgery. 6 months after, the sutures are gradually being removed already. This eye is doing pretty well. Vision with this refraction is 20/70. And 1 year after surgery, after all the sutures are removed, in this case of a combined big bubble and manual dissection, the patient sees about 20/25, 20/30 with glasses, wears a soft toric lens, and is very pleased. So in other words, in this case, we didn't get a big bubble, but we continued with lamellar dissection and still the result was really wonderful. What about this case? So this is a patient that we did manual dissection. K2 is 78.1, Kmax is 92.6, and the minimal thickness is 329 microns. So pretty advanced disease. And we're starting off with a garden tree fine blade that I'm not showing here in a partial thickness trephination. And I'm trying to inject air, but the air just goes to the chamber, either from the small perf in the cornea or through the trabeculum. And I'm just using this Morlad dissector to go layer by layer and remove as much of the cornea as I can. Now, at Wilmer, we are lucky. We have an intraoperative OCT that really guides us through all of this, but even if you don't have an OCT, you can tell when the cornea becomes very thin, it becomes very transparent, and then becomes also very soft. So you can tell that you're pretty deep. But in this case, as you can tell, the intraoperative OCT shows us that we don't have much stroma left over the cone, and over the superior cornea, there's maybe somewhere between 50 and 100 microns of residual stroma, which is pretty good. And at this point, we put the new graft on the cornea and suture it. And this patient was doing really well. I don't have the slide for this, but this eye actually has better vision than the fellow eye that has a PK. This is another case. So this is a patient with uncorrected vision of count fingers. She did get these intrastromal rings done elsewhere, and these rings did regularize the astigmatism, but still there's about 15 diopters of astigmatism here. And the Ks are high, and we decided that we're going to go ahead and do surgery for this cornea. And here we're doing the Mellis technique. So or sclerocorneal tunnel is created, and this Morla dissector is introduced deep in the stroma to create a pocket as deep as possible. And now we're cutting essentially the overlying stroma, removing the intacs as well, and suture the new graft on top. In this case, we had a small perf, but you can tell that this is post-op week 7 and the cornea is clear, vision is 20/60. And this is after more than a year after surgery, after all of the sutures are removed, and the uncorrected vision here was 20/30, which was pretty remarkable. I was very pleased with this surgery, and so was the patient. Just so you see here, the Ks are almost normalized. KM is 46.5, and the astigmatism is 1.6 diopters. What about the other eye of the same patient? So the uncorrected vision here was 2600, pinholes to 2125. And this patient was super happy with the other eye, and obviously wanted to go ahead and do the other eye as well. K max is 87.5. The thinnest point is 320 microns. So this is a very advanced case of keratoconus as well. And in this case, we did groove and peel. So let's see how we did it. So we start off with a partial thickness trephination with a guarded tree-fine blade. And these are Cindy scissors or DALK scissors that are used to propagate this initial groove and just go 360 degrees around. Sometimes you have to go to do another go around, another 360 degrees. Using the Fogla dissector here, just to sort of separate the last fibers. And then we pull on the remaining cornea, and we tried to do it with a large base to minimize the forces on the remaining decimae and stroma. And you can tell, I'm just gonna show you again here how clear the cornea looks at this point. I mean, you can look at the reflex over the pupil. This is a pretty clear cornea. So very little stroma left in this case. And this is this patient 1 month post-op. Vision is already 20/70 and pinholes to 20/40. KM is 42.1 with the sutures in, much reduced astigmatism. The OCT shows that there's barely any host stroma left in this case. And 3 months post-op, the cornea is clear. And this is what it looks like 1 year post-op after selective suture removal. So with the -0.5 plus 1.5 at 17, this patient gets to 20/25 with glasses. The astigmatism is 1.3 diopters. So, and this was done not with a big bubble, it was done with groove and peel. What about this case? So this is another case of groove and peel, a patient, 69-year-old male, with high myopia, post-LASIK aptasia, severe glaucoma, and best corrected visual acuity with glasses on top of a scleral lens was 20/40, and we decided to go ahead and do DALK in this case as well. So Kmax is 70.9, the thinnest point is 355 microns, and we have a Flyringa ring here. We used a guarded tree-fine blade, the 300 micron guarded tree-fine blade to do the partial thickness trephination. And I'm just lifting that ledge with a bun forceps. I use the Fogla dissector to go deep into the stroma, and then the Cindy scissors are introduced into that groove, and they propagate the surgical plane 360 degrees. Here in this case, I'm using a Pofik knife just to recreate the surgical plane so that I'd be able to introduce the Cindy scissors, and the tissue is now being peeled off. I think that you're getting a little bit of a choppy image for this video, but now essentially the corneal button is being peeled off. And now we're going to put the new cornea on and suture it. Then this is the intraoperative OCT, again, over the cone. It's pretty thin. I think that I probably left a little bit more stroma here, but it should be somewhere between 50 and 100 microns. At least this is my estimate. And again, this cornea, as you can tell, at 1 month post-op, it's pretty clear, and it pinholes already to 21, 25. This is the post-operative OCT, and you can tell here that there's very little host stroma left in this case. This is another patient. This patient vision with the scleral lens was 20/40, but this patient had progressive disease. There was a gradual increase in K2 and Kmax, and the thinnest point was 322 microns. So we figured that maybe cross-linking is not the best way to go forward, and maybe just go ahead and do DALK. Also, the other eye had DALK that I did, and this patient was happy with the results, so it was pretty easy to convince this patient to go ahead and do DALK in this case as well. So here, Kmax is 72.1. The thinnest point is, as I said, 322 microns. And we did the groove and peel, and this is what this eye looks like after selective suture removal. So a clear cornea, and with this refraction with -2.5 plus 1.5 at 10, this patient gets to 20/25, and KM is 44.7, and this is another nice result with a groove and peel. So groove and peel DALK is not something that I invented. It was invented by Rishi Swaroop and Dr. Sangwan, and it was an abstract in AAO in 2008. And this is a form of a pre-decimetic DALK where the risk of perforation is lower than in other types of DALK. So this is why it's a great way of doing DALK. In a big bubble DALK, we try to create this type 1 bubble where we separate Dua's layer together with decime from the overlying stroma. Sometimes we get the type 2 bubble where decime is separated from Dua and the overlying stroma, and this is why this is a very thin structure that is prone to rupture. In groove and peel, we aim for the pre-decimetic layer. So it's a slightly anterior to Dua. And after we do the 360 degree dissection, we just grab onto the tissue and we peel it. And because the posterior stroma is soft, especially in keratoconus, then this thing really peels off very, very easily. Now, a couple of useful tools that make life much easier when you're doing groove and peel is, first of all, a guarded tree-fine blade. There was a company that was producing this. We no longer, I think that they stopped producing this type of tree-fine blade, but we will probably transition to a Hannah-Baron tree-fine blade pretty soon. The pointed focal dissector is very helpful. It helps you essentially go deeper into the stroma after the partial thickness trephination. And the Cindy DLEC scissors are those scissors where the curved scissors that have the blunt tips, and they help do the rest of the dissection. So a couple of surgical pearls. You definitely want to go as deep as possible with your partial thickness trephination. As I said, I use the guarded tree-fine blade set at 300 microns. It's definitely better to go as deep as possible without perforating, of course. If you start too superficial, then you're just gonna have to do many, many rounds of dissection with the Cindy scissors as opposed to 1 or 2. The pointed focal dissector is used to go deeper and create a deeper surgical dissection, and then it allows the Cindy scissors to propagate this plane. I try to go relatively superficial and the first go around with the Cindy scissors, and then deeper with the second go around. And the reason for that is that if you do perf in the second go around, you still have sufficient, you still have gone deep enough in the first go around to peel the tissue towards the area of the perforation. Finally, you definitely want to try and peel the tissue with a large base, maybe with the two 0.12s or just grabbing that entire thing with a 0.12 and a way that would distribute the forces on a broad base. That way, you minimize the risk of perforation. It won't be a single point in the remaining stroma and decimate that is getting all of the force of the pole. So again, just to reiterate how we do the groove and peel. So we do the first go around or the second go around with the Cindy scissors, and then we try to pull the tissue going from the thinnest point to the thicker point in the cornea. If you don't believe me that you can go pretty deep with groove and peel, this is a study that we published in Cornea. And here we took cadaveric eyes and we performed groove and peel on these eyes. So you can already tell just by this picture how transparent it gets after the groove and peel, which means that we didn't leave a lot of tissue behind us. But this is the H&E stain that shows that essentially the very center of the cornea just has decime, dua, and maybe one or two layers of stromal fibers. So if you want to, and you're courageous enough, you can definitely go very, very deep with groove and peel, and it might have comparable results to big bubble. So to summarize, in general, even if you don't get a big bubble, it's really not the end of the world. And there are many, many ways to do deep anterior lamellar keratoplasty. Obviously, you want to aim for the minimal amount of residual stroma, and you definitely get that in big bubble, but you can also get that with other ways of doing lamellar dissection, including groove and peel. And the visual results are really wonderful. So don't be deterred, and if you try to do a big bubble and you don't get it, don't convert too quickly to a PK. At least give groove and peel or any other form of manual dissection a chance before you give up and move to PK, which is always an option. Thank you so much for your time and for listening. This is my email, and if you do have any questions for me, you can always email me at this address. And I think that at this point, Michael, we're gonna open the floor to questions.
Yeah, so everyone who's on the call still, please feel free to enter any questions for Dr. Soiberman into the Q&A panel. And I'll just start it off with a quick question just to give everybody some time to enter those, unless you're all experts on manual DALK already and don't need any help. In your surgical practice today, do you generally attempt a big bubble and use the manual technique as a backup, or do you go straight to a manual dissection?
So I'll be very honest. We are big proponents of groove and peel, and we've had beautiful results with it. And I just go directly to groove and peel. I know that the results are going to be reproducible. I know that the likelihood of perforation is really low. I know that the visual results are great. I mean, I see these patients, so I just don't see the point in even trying to do a big bubble. I used to do that in the past. I would start every DALK with an attempt for a big bubble, and then if it would succeed, then great. And if it didn't, then I would go with manual dissection. But I don't do that anymore. And I know that many other cornea surgeons are also attempting some form of groove and peel, where the grip and rip or other types. So I think that this is, at least for keratoconus, this is a great option. For patients with corneal scars, it's a little bit of a different story because the posterior stroma is not as pliable. It's just not soft enough. In these cases, I think that I would still consider doing a big bubble first. The advantage of trying a big bubble is that if everything turns white, then at least you have a good marker of where there's remaining stroma, because essentially the emphysema just stains your stroma in white. The disadvantage is that if you get an inadvertent type 2 bubble, then you really have to be very careful. There's a limit to how deep you can go in the cornea without perfing that type 2 bubble. And some points you really have to go with sharp dissection, which, it's just a matter of being comfortable, right? I don't feel super comfortable doing a sharp dissection with a crescent blade when I'm deep in the cornea. I just saw Susan Jacob do it without even thinking twice. So for some people, it's like super, like not a problem. I feel less comfortable with that.
If only we could all be Susan Jacob.
That is so true. She's pretty amazing.
She is amazing. And so we have a question in the chat here. What would you say is the thinnest cornea that is viable to attempt this technique? I think the groove and peel.
No, any cornea. I mean, I don't think that there's a limit, because really, as you can tell with all of these manual DALKs, the problem is usually not the cone. Over the cone, you almost always get a very, once you peel, once you do manual dissection, you get very little stroma over the cone. The problem is really the periphery. You want to remove as much tissue as you can from the periphery, because if you leave too much, then you just have this this heaped up or a little hill that you can't really see when the sutures are there. But once you start removing the sutures, you have a little bump there, because the remaining stroma just pushes your graft up. It doesn't really matter what the central thickness is. This is what I'm trying to say. Even very thin corneas are amenable to this technique. It's all about removing as much of the peripheral stroma as you can and then peeling it to the center.
Great. All right. Well, it looks like, one more question. Does the presence of Decimet's tears or prior high drops change your approach?
It does, because I don't think that, it depends, first of all, when. If it's fresh in the first few months after high drops, then I would say that, I wouldn't even try doing this technique. Having said that, we all know that Susan Jacob, we just mentioned her name, she's a big proponent of early DALK for high drops. I would feel a little bit more, less comfortable doing that. I think that in the case of a D-tear, if I do decide to proceed with keratoplasty, I would probably do some of it with sharp dissection, just to minimize the chances that I'm going to rupture that unstable scar. If it's later in the game, then I think that it's possible. You can do it. You just have to sort of gauge how the cornea is behaving, and as you're pulling and trying to peel it off. And if it's not peeling off from one side very nicely, then I would go to the other side. And if you can't peel it all the way through the scar, then I would peel just the periphery and then remove the remaining stroma with a crescent blade or with something sharp. But thankfully, usually many, or at least not usually, but many patients who have high drops, I mean, the cornea flattens so much that some of them have better vision, and then they just don't need any form of keratoplasty. So that's something else to bear in mind.
And we have two more questions that came in now. The first one is, you highlighted the depth of trephination at 300 microns. Is that just to apply to keratoconus cases, or would you say the same for other adult cases like ulcers or scars?
So this is where I started off, because I feel that this is a good place to start. Usually in keratoconus, around that area, if you use a 7.5 or an 8 millimeter tree fine, then around that area, if we're talking about an advanced cone, the thickness is usually somewhere around 400 to 500 microns. So if you start off at 300 microns and you actually get what you're aiming for, it leaves you something like 100 to 200 microns of peripheral dissection, which just makes your life pretty easy, because all you have to do is go in like maybe 100, 150 microns, and this is it. It's perfect. I did a case like 2 weeks ago that I did a trephination. I did the partial thickness trephination at 300 microns. We did one round Cindy Scissors dissection, and I used the OCT, and I was like, oh wow, this is really thin. We don't need to go any deeper. For other corneas, non-keratoconus corneas, the thickness at the 4 millimeter zone can be much higher than 400 or 500 microns. That could be 600, it can be more. So in these cases, I would use maybe the 400 microns tree fine blade. I would try to go deeper. That's the bottom line. So not all cases, I mean, this is not a recipe for all cases. This is more of a recipe for success with keratoconus corneas. With the normal corneas that have central scars, depending on the pentacam measurement around that area, I would consider going deeper.
And then the final question, if only Descemet's membrane is remaining during DALK, is there a risk of Descemet's membrane rupture?
You mean, if you mean, if you're asking whether there's a risk of rupture when you do a groove and peel, so I would say that there probably is risk of rupture, because Descemet's membrane itself, as strong as it is, I mean, you need to apply quite a bit of force to peel it off. I wouldn't try to aim to remove all of the overlying stroma. I mean, I would definitely try to keep a few layers of stromal fibers to reinforce Descemet's membrane. I think that there is a risk for perforation if you go super deep. In the eyes that I've done for the cornea study, and I was definitely aiming at going as deep as possible, as you can imagine, we did have a few microperfs. They were all peripheral, because remember, all the dissection is done peripherally. So it didn't matter that much. I just put a little bit of air in the anterior chamber, and I did all of the pulling towards the tear or towards the perf. And then nothing happened. It went really well. And I was able to still maintain 99% of Descemet, which in DALK is great. I mean, you just end up the surgery with a little bit of air or S6 at the front and the anterior chamber, depending on whether the patient is phakic or not. Yeah, I wouldn't go super deep, if that answers the question.
What is, and I'm curious, based on your answer to that last question, what's your threshold for conversion? So you said you had some micro perforations and proceeded. Have you ever experienced any larger perforations?
Yeah, I have, but not so much with groove and peel. I've surprisingly, with the Mellis technique, I've had much more macro perforations that I just realized that there's no point. I mean, especially if it happens in the middle of the dissection. With the groove and peel, knock on wood, so far so good. Haven't been any micro perfs. With the big bubble, I've had perfs, and they can happen at any point. The most annoying is obviously when it happens after you created the big bubble. But groove and peel so far, it's been pretty good. If it's a very small perf, just 1 millimeter or so, even if it's a little bit bigger, I don't think that it's a big deal. I've had, you know what? Let me take that back. I did have one micro perf with groove and peel, and I just peeled everything towards the perf, and it still worked beautifully. I'm trying to think of other instances. One of the cases that I presented here, the Mellis technique had a small central perf, and still that cornea did very well. So if the perf is relatively small, just continue as though nothing happened, put some gas in the eye. These eyes do well.
Great. And one last question came in. Pardon me. What would you say is the learning curve for groove and peel DALK, maybe in terms of number of cases?
So that's a good question. I think that if you have, it's not just groove and peel. You do need to have some a minimal skill set of lamellar dissection in the cornea. If you know how to do that, then you can do groove and peel. It's much easier to do groove and peel than to do manual dissection. I think that the main challenge in groove and peel is to know when to stop, when not to go too deep. But on the other hand, the big question is, or the other challenge is not to go too shallow. So that takes a few cases, but I think that the learning curve is relatively quick. And again, this is a much more reproducible technique than big bubble, at least in my hands. And other cornea experts that I've worked with, and I showed them how to do this, their response was, "Oh, this is so easy." So I think that this is, once you get the hang of it, it's a pretty easy technique. So I don't think that it's a steep learning curve. I don't think that it takes very long or many cases to learn how to do it well. And just remember, even if it doesn't work and you're not happy, you can always do a PK. Again, it's not like if it works and you still didn't go deep enough, you can go back and go deeper. You're not introducing new endothelial cells into the eye. I'm not sure that it's the same rejection or rejection statistics as in a second graft. So I think that it provides you some safety, even during the learning curve.
Well, that last question was from Dr. Comiskey, so it sounds like he's ready to get in the OR with you, do some cases.
Yeah, he's trying to hint.
Yeah, little hint for you. And it looks like that's all the questions we have.
Sounds good.
I just want to say thank you so much, Dr. Soiberman, for presenting tonight and sharing your expertise with us. And thank you to everyone who joined in and for the questions. That was a great discussion. When you log out of the webinar, you'll be given a short survey. Please, I think it's like 2 questions. Please fill that out really quickly if you have a chance. And that's all. Thank you.
Yeah, thank you, Michael. Thank you, Eversight. This has been great.
Yeah, absolutely. Have a good night, everybody.
Bye.